I want to introduce one by one the members of this very distinguished panel. And I'm going to begin with John Rowe. We call him Jack, who you'll know he's in your bios. You'll have all the bios. Professor, Columbia University, Mailman School of Public Health. And he said, please tell them I'm a fellow of the American Academy of Nursing. A very proud standing. Please have a seat. I'll sit down too. And Tara Kozlov, who is the Deputy Director, Office of Policy Planning, Federal Trade Commission. Oh, it's like we have a big show here. This is nice. Come on in, Tara. Micah Weinberg, Senior Policy Advisor, Bay Area Council, also Senior Research Fellow at the Bay Area Council Economic Institute, and I think that's important. Frederick Isasi, who is the Director of the Health Division, National Governors Association, Center for Best Practices, and ta-da, Elaine Ryan, very dear friend and colleague, Vice President, State Advocacy and Strategy for Integration, AARP. So welcome to this wonderful panel, who is going to pick up where we left off before. And I'm going to start with sticking to policy barriers a little bit more. These are folks, some of whom are very involved in legislation and regulation, certainly people involved in the practice arena and health system area also. But I'm going to start with those policy barriers that exist at the state and federal level. I'm going to turn to both Frederick and Elaine first, if that's okay. And Frederick, if you could first talk about states, the two of you. What do you see as some barriers before we get to more concrete solutions?
Sure. And I should start by saying that my comments are off the record and my own, not the official position of the governors. I always have to say that, yeah. So I think...
You've given up your First Amendment rights.
Exactly, exactly. I think what we've seen is that there's an enormous amount of variation state to state in terms of the way that advanced practice nurses are being utilized and the things that they're authorized to do. So, for example, only about half the states truly have some form of independence with their advanced practice nurses. Only about a fifth of the states have truly independent nurse practitioners. We know that there's still about 20 states that aren't reimbursing nurse practitioners for Medicaid, within their Medicaid programs for primary care. And we also know that only about 4 states actually require that third-party payers pay advanced practice nurses for their services in primary care. So there's an enormous amount of variation, and really this is about carefully thinking through all of the strategies that states can leverage to embrace the role of advanced practice nurses to, as many of the panelists have said earlier today, to both drive down cost, improve quality, and meet the workforce challenges and needs of their communities. So I think we're working very hard within the Center for Best Practices to work with states to think about what are those menu of choices and options that they should consider, and how can they work through each of them and then come out with a policy that optimizes the use of the advanced practice nurse.
Is it fair to say, even on the record, that there is interest among the governors?
Well, I can't say anything on the record,
okay.
So just very clear there. Okay. I work on the center side, so I don't ever...
Have you seen any interest anyway?
We've seen a lot of interest. We've seen a lot of interest. Okay. The governors, it's really quite inspiring. The governors really feel the need of their constituents deeply. They are, I have to say, I worked in the Senate for a long time before coming to NGA, and the level of interest on workforce issues coming from the governors is so much higher than what I experienced working in the Senate. They truly, you know, they drive to work every day in their communities. They see the need, and they are very inspired by wanting to meet those needs. So I think governors have been very active and are excited about sort of leading the charge in terms of driving towards a more efficient, high-quality healthcare system.
Oh, and we'll come back to you. You can
Sounds
think
great.
about federal while Elaine's
Sure.
talking.
Sure.
So Elaine is out and about. Elaine is responsible for advocacy among all state offices for the AARP. And so she's just come back from Portland, actually.
Yes.
So what are you saying? What barriers do you see, Elaine, from your perspective?
Well, from our perspective, and I want to talk not only as an advocate in the states, but also from a consumer perspective. I think 2 things. One is there are far too many barriers that exist in state law, in regulation, in payment, that frankly lawmakers don't even know exist. And so I think that what we see, if we have 19 states in the District of Columbia that's allowing nurses to practice to the top of their license, what do they know that other states don't know? How can we more effectively communicate the sense of urgency for change? I would say that in our experience, as you know, AARP has our real possibilities. If there was ever a real possibility to achieve a standard where people can practice to the top of their education and skills, where we know that it can be delivered with high quality, lower cost, greater access. The question isn't respectfully doing more research, though I know that you're bailiwick. I think it's effectively communicating to state policymakers, to governors, state legislators, what's going on in their state, why they have these rules, how to change them, and why it matters. And I would say that we saw through our state advocacy this year a movement in Minnesota, which became the first state to this year to actually expand those laws, but also in Louisiana and in Kentucky. These are hard-fought battles. Some, like Nebraska, where got it through the legislature, didn't prevail with a governor's signature. What can we do more effectively to communicate the why? And so I just want to talk about a family caregiver perspective. So I was a family caregiver for my parents for 15 years, and I saw up close that nurses are lifesavers. They are the central point of any case, whether it's in the doctor's office, whether it's in the hospital, whether it's in rehab, or whether it's at home. They are the locus of healthcare delivery in my experience. But I also have experienced home care where I couldn't get any ability for a nurse to be able to prevent my mom from getting into a wheelchair van, going 8 blocks, going to a doctor's office, seeing a nurse practitioner in the doctor's office, then seeing the doctor, then getting back in a van, and then back home, which, by the way, took the entire day. When Nurse Sue, God bless her, could have been the person who knew her, who could be able to care for her and be able to practice at the top of her license, but was prevented from doing so. We need to catalyze a sense of urgency and change. We have to go state by state, but our messages don't have to be sui generis to a particular state. And I hope to talk a little bit more about what we can do moving forward.
Good, we'll do that. I think Jack wants to respond to one of your points.
Yeah, I do. I agree with everything that's been said here and the things that were said in the other panel with respect to the barriers. But I think there's an important dimension missing in the conversation here. It's true that there are barriers in many states and that the legislatures are important, and maybe the state's Department of Medical Licensing or whatever it is important. But, you know, the problem is the physicians. I mean, let's not make believe that the problem is not the physicians. If the physicians were really in favor of this, we wouldn't have this panel, okay? You know, so, and if you look at the states, sure, there are 19 states where nurses can practice independently, but there are all those rectangular states up in the upper left where there are no patients and no doctors, you know? I mean, the doctors are not threatened in those states because there are so few physicians and there's large rural areas and no care available from physicians, and of course the legislatures have provided opportunity for nurses to practice, so I think we have to be realistic about the fact that the barrier in many of the remaining states is the implicit threat of adding another cadre of, by the way, now documented to be fully qualified and perhaps even less expensive providers during a time in which physicians in practice feel tremendous pressure on their profession and on their incomes, which I understand fully. So I think that that's an important consideration that we just should at least have on the
Put it
table.
on the table. Looks like you want to respond, Fred.
I just wanted to kind of echo those comments, and I think there's another dimension to all of this that's worth discussing, which is at the core of a nurse's training, there is a patient-centeredness that we don't find in the traditional physician training. That center, a growing body of evidence shows, provides a much more efficient and high-quality level of care. And we know the research indicates that advanced practice nurses are providing as good a care as docs. But I would argue that when you think about the transformative efforts around the country towards driving towards population health and migrating providers to risk, there's a core to the way that nurses are trained that really plays into that research and that drive. And I think that also is at play here because there's a real resistance from a lot of the physician community about this shift. And so there's a few reasons why I think we're seeing the resistance on the state levels sometimes and on the federal level sometimes.
I think Mike has experienced that perhaps in California.
A little bit. But actually on both sides. So I want to reground this in the sort of business case for these innovations and these changes, because the California Association of Physician Groups is, as far as they know, the only physician association in the history of the world to endorse expanded scope of practice for nurse practitioners. And their chief advocate was working side by side with my employer organization and with AARP last year. We differed a little bit on the substance, but it's because they represent these groups that are already so in California, the future is already here. They represent these enormous groups which care for almost 20 million people that are delegated and capitated for the most part. So they're already being paid in the way that we're trying to move payment reform nationwide. And so that means that it's actually in their financial interest. It's in the interest of the way that they structure their organizations to be supportive of these reforms, and hence they are.
Let me
Yeah.
just for the record.
They don't need a moderator.
The American College of Physicians, which is the largest professional physician organization in the United States, larger than lesser organizations like the American Medical Association, has also endorsed the future in nursing recommendations from the IOM report. And did I have anything to do? I just kept out of the way. That was my contribution. I think the point to be made, which improves the point I made, it's not all physicians by any means. And it's not even all physician professional organizations by any means. But for historical or other reasons, there are physician groups that have significant influence in various state levels in various states. And those seem to be the impediments. But I think you're absolutely right.
Yes, I was going to turn to
You know, unfortunately, I've had 30 years of advocacy experience, so I'm going to just share that I think that from both sides, both working for a governor and a member of Congress and then lobbying them on the other side, I think what's important to note is in this discussion, if we start pitting one group against another, that's a recipe to policymakers to do nothing. When they have to choose between doctors and nurses, that's a false choice, and we heard from the business panel, an unnecessary one. There's more than enough demand for services. There's more than enough trend toward patient-centeredness, home care, medical homes, to justify why we're making these changes. And I'd like to see dialogue change so that the power of consumers, businesses, people who are forward-thinking, pushing policymakers to realize what they realize every day at home, is that consumers are driving change in the way we access healthcare today. And that consumer voice is a critical one to bring not only to state legislatures, but with businesses, with physicians, with nurses. If we start off fighting, we'll end up nowhere. And so here's hoping we can fashion a broader coalition of change.
That's certainly our goal, and we have 50 state action coalitions that are involved in the campaign that, using their own dollars and AARP resources, actively lobby on these issues, trying to bring together business and consumers and other caregiving organizations, other stakeholders to the table. We saw that in California. Tell us what happened in California, because I think it's interesting. It's not just the physician in general resisting change. Very concrete things can happen. If you don't remember, I'll fill them in.
Well, there are a lot of concrete things that happen.
Okay. I was thinking of the union. Wasn't it the physician?
Yeah,
Yes.
yeah. I mean, well, yeah. It really we have a union. Actually, our chapter of AFSCME represents a lot of employed state physicians, and they were instrumental at the last minute in really stopping the momentum that we had, getting it through a couple of the committees. There are various strategies for dealing with this. But it is, I agree that you don't want to frame it as a fight, but it does become a dogfight at some point. And you know, near the end of the legislative session, very openly, the Medical Association was going around, because one of the things that research that my organization has done and other organizations have done have shown that it improves access. Changing these scope restrictions improves access, both by freeing up nurse practitioners to do more of what they're already trained to do, and also by reducing the administrative burdens on physicians to unnecessarily oversee this nurse practice. But it creates access, in particular in a lot of minority and underserved communities. So at the end of the session, the CMA, California Medical Association, was going around to the legislators that represented these communities, essentially saying, congrats guys, you're going to get second-class care. It's doctors for the wealthy communities and nurses for the poor communities. And so, you know, these legislative battles get pretty nasty, and so continuing to ground it in the evidence, continuing to ground it in the data, and showing how this is happening throughout the nation is consistent with the reforms that are going on in the broader health system, like Mark McClellan mentioned, is really essential.
And the consumer stories.
Yeah.
Tara, I wanted to ask you, because you, sitting at the Federal Trade Commission, have a broader view, I think, of the regulatory issues that come forward. Can you tell us what's going on from I pointed out to the report in the packet, but say a few words about what's going on.
Sure. I do need to issue a similar disclaimer. I don't speak on behalf of the Commission or any of the commissioners, although I will note that not only that policy paper, but every single state advocacy that we've done has received a unanimous vote over many years from a bipartisan commission of 5. So I do feel like I'm on fairly comfortable ground here.
And this is all on the website?
Everything is on the website, yes. So if you go to the policy tab and then you click on advocacy, you can search by topic, and if you look under healthcare or nursing, you can find a wide range of our advocacy materials. And we do view this, for us, as an important element of what we call competition advocacy. As many of you know, we are primarily an enforcement agency, but we do also engage in a great deal of advocacy. And just to pick up on some of the themes I've heard from a few of the panelists, I agree that as an advocacy technique, the idea of building coalitions and not dividing people up is effective, but from our perspective in trying to frame this as a competition issue, when we go out to states, what we are really trying to do is encourage these state-level decision makers, the legislators and the regulators, to be more transparent about the concept that this is a competition issue. This is a situation where you have one group of providers who may feel threatened economically, financially by another group of providers, and what we encourage the decision makers to do is to really step back and reframe this. So let's start with, is there a legitimate health and safety issue that you're trying to solve here? We have a deep base of evidence that we try and lay out, and this is what we do to a great extent in the policy paper. Take that off the table. There really is not a health and safety issue here. If you still believe there is some health and safety issue, let's go to the next step. Does this restrictive regulation on scope of practice actually solve whatever problem you purport to be identifying? Or is there a significantly less restrictive alternative that would promote the goals of competition, would promote the needs of consumers, and achieve the triple aim without unnecessarily stifling competition? And so we don't necessarily purport to have the answers, although I think that the policy paper goes about as far as we've ever gone in saying we do think there is a right answer here. But we feel like if we can at least encourage the state lawmakers to walk through that framework and ask the questions in that way, starting from that premise that the competition would bring a variety of benefits to consumers in terms of financially, access to care, quality of care, promoting innovation in the way the care is delivered in the first place. If you walk through the framework that way, we are hopeful that more of the states that have not crossed over to expanded scope of practice will come to this same consensus view and will hopefully be able to push the dialogue in that direction.
Tara, how does the state get you involved?
So typically what happens is we receive a request from a state legislator or regulator to comment on proposed or pending legislation or regulations. Occasionally, if something is put out for public comment, if it's a regulation where there's a 30-day public comment period, we might be able to just take that as an invitation and we don't need something specific. But more often we would get a letter asking us to comment and then we would be responding to that comment. Over the years, we've done a number of these state-by-state comments, and part of why we ended up issuing the policy paper that you all have in your folders is we thought that it might be useful to the entire advocacy community as well as to people in the states if we could synthesize some of the arguments that we had been making on a state-by-state basis, put them together in this policy paper, which then also magnifies our force because hopefully that paper becomes an advocacy tool that all of you and others in the advocacy community can use since we cannot be everywhere, and it allows you to take some of the work that we've done and maybe put that forward to other audiences. And I will say we have gotten fewer requests for state comment since we put the policy paper out. I think because the policy paper is serving that goal, it has become its own effective tool.
So you're happy about that?
I am very happy. As one of the co-authors who slaved over that paper for a long period of time, including during the furlough last year. We had a hiatus where it was almost exactly a year ago. It was almost done, and then we lost a month. But we're very happy that we finally got it out.
Okay. I just want to touch on federal issues for a moment. We've been pretty much sticking to state issues now. Frederick, I don't know if you're the right one to answer this, but aren't there federal barriers as well as state? Can you say anything about them?
Sure. There's quite a few, and typically they track into the federal healthcare programs, in particular Medicare. And I'll give you an example. We were working. This is back when I was in the Senate. We were working on an expansion of Medicare medical homes, and the question was who was going to be able to receive the medical home the payment for coordinating care for patients. And what we know is, in practice, very often nurses are actually the ones who are at the helm. But under Medicare law, it has to be a physician to receive. A physician is the person who actually certifies as the head of the medical home and receives the payment. Why did that happen? That happened because basically we ran out of money. We only had money. CBO will tell us if we expand the scope beyond docs, we include nurse practitioners, it's going to increase the score by X amount. And people just decided, well, we're doing this basically to assuage a concern that we're getting out of the physician community. So as long as we check that box, we're okay. And we don't have enough money to expand it beyond that. So it's not a very good reason, but it's very realistic. That plays out a million times in federal legislation. There's other great examples of the same problem. I mean, why is it, for example, that nurse practitioners can't certify SNF care?
Say what that means.
Sorry, skilled nursing facilities. So as a patient gets discharged, say from an inpatient treatment and needs to go into a skilled nursing facility, nurse practitioners aren't allowed to actually certify that need and then come back in and do the monthly checks that are required. And for example, that could very well be one of the reasons why your mom ended up having to get on that transport and go and see a doctor and take the whole day. And instead of having a nurse coming to her home and doing this, it's there's always, well, at least two reasons. One is it likely to create fraud, or are there problems around fraud that we're hearing from the research community and from experts? That's never been raised as a real concern at all in this front. The second is, well, if we allow that to happen, we're going to get more certifications. That's going to increase the cost of the bill, so we can't afford it. You know, and so again, these aren't for great reasons, and it really is. I think everything that you've said has been so on point. A lot of this is about educating folks to let them understand the impact. So, for example, the story you just told, if you could get members to understand, you know, this is why you know, the folks who you care about and you're representing are having to do things like take their frail or elderly parents, put them on a transport to get them in to see a doctor who really isn't providing any care. It's all nurse-driven. That's really powerful. And so I think most of this is about helping states and the federal Congress and federal authorities understand the impact within the healthcare delivery system of these rather arbitrary policies.
Mm-hmm. I would just say that our AARP this year has launched a multi-state family caregiving campaign across the country. And our lens and the reason why this issue has risen to the top of our AARP dashboard measures is because family caregivers and their loved ones see the system up close. They see things that don't make sense. They know, as my dear sweet departed mama might say, something's radically wrong. No way can it be less expensive to be able to have duplicative systems like these. So family caregivers are 42 million of them, by your own research, provide $450 billion of unpaid care in this country every year. They see the healthcare system up close. I think that in our advocacy, telling the story of the consumers, the caregivers, and in all due respect, it's not about the providers and it's not about the payers, but it's really time to put patients first. If we looked at it through the eyes of people who are going to minute clinics, but then couldn't understand if they cross a border why they could get certain services in one state but not in another, something needs to change. It's how people access care. It's why we need to drive that kind of change, and with the smarts of everyone who knows the research, the data, the law, we can undergird that sense of imperative because the time for change is really now.
Absolutely. And, you know, I wanted to say too, we had authored the expansion that made it into the ACA. We had authored earlier in a bill that was introduced. The primary thought leader behind that legislation was a Robert Wood Johnson health policy fellow in our office who is a physician and really got it. So just going back to that earlier point, there are tons of fantastic, really thoughtful docs out there who really get this, and often they're there fighting hard for this. You know, this kind of dichotomy that we see, it's often about how does that physician perceive themselves? You know, do they perceive themselves as a small business person who's sort of fighting it out for their own, you know, practice, or do they see themselves as an advocate for their patient? And so I think this particular Dr. Dan Dirksen, who's now a professor at Arizona, he was every day he'd take meetings and he'd push hard to say to his physician colleagues, this is ridiculous. Of course nurse practitioners should be the lead. I mean, every medical home that I've been associated with, it's been a nurse practitioner at the lead. Why wouldn't we have them in the legislation?
Well, kudos to RWJ Foundation.
Yeah,
fellows
absolutely.
for being in the right place.
Absolutely.
And here's this one smart physician here too, who's also a business leader. And I'm wondering about the business world too.
Yeah, I'd be happy to comment on that, but let me follow up on what Elaine said. I think she says it very well, and I want to clarify. I think there are two issues here. I think one of the issues is understanding where the resistance is and what it is based on, because you can't have an effective strategy unless you understand that. On the other hand, I'm a physician. I was a practicing physician. I was president of a medical school for 12 years. You know, I'm not advocating we go to war with physicians. In general, if you want to make a change in the healthcare system, going to war with physicians is a bad strategy, okay? And so I would agree. I think that the point is that when you talk with stakeholders and policymakers, You don't want to frame this as it's us against the physicians. It's not about the doctors. It's not about the nurses. It's about the patients. And that's the focus. And it's access to care when there's a tremendous and growing deficiency in primary care providers. Providing people with health insurance and not access to care is a hollow promise. So I certainly agree with that very, very much. But I do think there's a distinction between recognizing what the problem is and then what is the strategy to go about solving it. As far as corporate issues are concerned, I think there are a couple levels. I mean, there are the corporations of healthcare. We've heard from Cigna and Aetna and some of what they're doing, and I'm sure United and WellPoint and Humana and HealthNet and the Blues are all also doing similar things because it's very much in their best interest and it's the right thing to do. But I think that most people underestimate the importance of the rest of the corporations. When I was the CEO of Aetna, 80% of my customers were in employer-sponsored plans that were self-insured. If you took the Fortune 100 companies, 86 of them were my customers. And many of those corporations were very prominent in their communities. If I had a problem with the contract or the rates at the single largest hospital in Wilmington, Delaware, I called the CEO of DuPont, who happened to be one of my customers. I didn't call the CEO of the hospital. And when I had a problem in Houston, I called the CEO of ExxonMobil. And you cannot overestimate the impact that these corporate leaders have on the behavior of healthcare organizations in their community. And if Kodak and Xerox and PayPal decided that they really wanted to see ACOs in Rochester, New York that used advanced practice nurses to the top of their license, it wouldn't happen immediately. It would take 3 or 4 minutes. But it would happen. And there are organizations like the National Business Group on Health, led so effectively by Helen Darling, who retired recently from that role, or the Pacific Business Group on Health that Peter Lee used to run, and in Minnesota and other organizations that bring together corporate sponsors, many of whom have terrific ideas. They're the sources of innovation very often, and the health insurers adopt these innovations because that's what their customers want, and because there's no intellectual property in insurance. If the health insurers one of them adopts it, then everyone else will adopt it if it is effective in the marketplace. And they'll change the name of it so they don't exactly have the same name as Randy's program in compassionate care, but it's essentially an effort to do a similar kind of thing because it was very successful, and employers loved it and employees loved it. And so I think that there has to be a recognition that corporate America is going to play a very, very significant role. And in fact, I think that's why you chose to have a title, The Business Case. That's right. Because you want to be able to make a case to corporate America that it is in fact in their best interest. And the important thing here is to understand that the healthcare, the companies in the United States that care a lot about healthcare are not just the healthcare companies. It is every company, because every company's largest or most rapidly growing expense is their healthcare costs for their beneficiaries. And so if you can have an impact on that, then you're going to have a significant impact. And you will find, and I'll tell you a little story if I can about the compassionate care program. When the compassionate care program was started, I suggested we do this, and the actuary said that you can't do this. That this is, and they were kind of rolling their eyes and dealing with me because I was an academic physician and I wasn't really an insurance executive, and they woke up one morning and I was the CEO, and obviously I didn't know what I was doing, and the company was destined for destruction, and that was not going to be a long trip because we were pretty close to destruction at that point, and which is maybe why I was there. We need a doctor, So I came up with this brilliant idea: we're going to insure people who are dying. And they said, did you ever hear of adverse selection? Every sick person, everybody with a bad diagnosis is going to sign up for Aetna. We're going to go down the tube. Did you ever hear of the term death spiral? And I said, no, we sell our insurance by group. We don't have individual underwriting. It's the employees. And I said, oh, no, many employees have a choice, Cigna or Aetna, and they're going to choose us if they're sick. I said, I don't think so, And so I went to 6 employers who were big, loyal customers, and I said, I want to do this. I think it's good for your employees. And they all liked it. And one of them loved it. And he convinced the others. And he just said, this is what we need.
Yeah.
This was a short guy, a wonderful guy who just thought this was the greatest thing since sliced bread. And that was a guy named Bill Marriott, who is a Mormon, actually, and who runs a Marriott hotel chain. He was terrific. So anyway, we got these 6 employers in the room, and I said to them, okay, here's the deal, guys. We're going to do this for a year, and I'm going to hold you harmless. You're self-employed. If you lose a lot, self-insured, you lose a lot of money because we're doing this program, and you get adverse selection, blah, 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 in your Aetna account, you lose money, I'll make.
That was gutsy.
It was obvious it was going to work. And the reason it was obvious to me is I'm not an actuary. I'm a physician. Because they didn't realize that what we were saving was the ICU costs and the unnecessary, painful, intrusive tests and diagnostic procedures and therapeutic, procedures that are futile. So anyway, to make a long story bearable, the point was that the only reason that program got started and is now a huge success and is copied everywhere, and many, many, many Americans are getting it. The only reason was that a bunch of corporations sat in a room with me and agreed that they were going to do it. So if you want to know if corporations are important, it's all about corporations.
And CEOs of insurance companies. Like, yes. I'm going to thank you for that, and I want to I'll get back to you, Fred. I think you want to talk. But Micah, you've done a lot of study in this area. Can you share? You mentioned your study a little bit, but can you say a little more?
So let me keep this as short as I can. So as you mentioned, I have a couple of hats. I do advocacy for the Bay Area Council, which is a 250 employer, large employers, Apple, Google, and so on, organization. But I'm also a senior fellow at the in-house think tank there. Mm-hmm. And as a policy advocate, I hate the variation among states on these scope of practice regulations. As a researcher, I love it. Because, it gives you a natural experiment. It gives you a research design. And so that's essentially what the work that we did does. It says, what if the states that haven't relaxed scope of practice restriction looked like the states that did? Mm-hmm. What would happen on quality, cost, and access? And showing that there would be more access, more nurse practitioners, particularly in rural and underserved areas. You would see decades of evidence that the quality is the same when measured by sort of procedural quality. And if you think about quality as increased primary care visits, there's a significant increase in primary care visits. And those primary care visits and other types of visits are less expensive due to things like what were mentioned around preventing additional more invasive services. Nurse practitioners have different prescribing patterns and so on. And so this research was published by the think tank of the Bay Area Council. And when I've presented it to and worked with the C-suite leaders there, they are all completely on board. There was no dissent whatsoever. They see the case for it. Most of them are self-insured. But I want to make an important distinction. When it comes to changing their purchasing strategies, they have pretty good leeway in terms of what they can do. Not entirely. They tend to be a little bit conservative in terms of things around networks and so on. When it comes to getting engaged in a lobbying battle at the State House, that's a different thing for these organizations. They're on board. They've committed resources. They're sending people like me to be engaged in these conversations. But it's not going to be generally in the top 10 asks for a legislator in any given year for that particular corporation if it's really just they're a self-insured corporation that's looking to decrease their amount of money. And so that's the challenge, because it is going to be in the top 10 asks of the California Medical Association next year. So one of the things I'm really excited about is the fact that a lot of large corporations now have an even bigger vested interest in these regulatory issues. The Targets, the CVSs, the Walmarts, really big groups, that this impacts their bottom line and their business model in a significant and different way. And I think that's really going to change the conversations and the outcomes at these state houses in the coming years.
That's great. I'm starting to get some questions from the audience. If you need to leave at 11:45, feel free to do so. But since we started later, I think we can spend a few extra minutes if that's okay with the panelists and with you. So I just wanted to make that announcement. And feel free to, Dilly, are you collecting as well as from the people who are tweeting? Okay, so the first question is for you, Frederick, anyway, and I think you wanted to say something. Is there any way to get CBO, Congressional Budget Office, to change how they make their estimates?
So before I jump to that question, the other point I was going to make was, first of all, just to really reiterate that self-insured plans and employers are so important. But I wanted to underscore, in many states, the largest employer is the state. And so I think it's so critical for both that reason and the reason you highlight, which is at the end of the day, it is unlikely employers are going to go out there and fight really hard about whether or not an NP has to enter into an agreement with a doc. Right? That's a very tough, very nuanced issue for them to take on. But governors really have both. They're wearing both hats, and they have a lot of interest in both places.
Very good point.
The other point I was going to make is remember as well as to your federal question that in so many cases the state payment policy is based on the Medicare payment policy. So take, for example, ACOs, as you mentioned. Right now in the Medicare Shared Savings Program, the ACO program, nurse practitioners can't actually trigger an attributed patient. So even if I am a Medicare Benny and I show up at my nurse practitioner and she's giving me her or he's giving me his primary care services, I don't get to be in an ACO. I do not trigger that attribution. And guess what? That trickles down into the state policies as well. So I do think the federal angle here is super important for many reasons. To the question about CBO, well, that's a question everyone's been asking. And the way that people always talk about CBOs, CBOs doing their job because both sides of the aisle just hate them, right? They don't know how to score things. They're always wrong on policy. But the truth is that CBOs do a really tough job. And there is really no easy way to ask them to change the way they score things. The best way is to provide them really strong evidence, peer-reviewed, hopefully randomized controlled trials that they can actually bank on. And you see them moving. There's been some movement. But really, at the end of the day, what CBO is trying to do is find very solid evidence to support an assertion that a spend will either go up or down. And at the end of the day, their job is to safeguard the federal taxpayers. So if you don't have really strong evidence, they're going to assume a spend. Their primary posture is not how do we figure out a way to say that less money is going to be spent? They're always going to start with, this is going to cost money unless you can really demonstrate to me that it's not. And that kind of is their role. So it's not, I don't think it's a great hole to go down, but the best thing to do is to do the kind of studies, the natural experiments that are happening, and demonstrate with real rigorous evaluation that the costs are reduced. That's the kind of stuff that's really going to trigger a reaction from CPO.
Could I just jump in and say, in all due respect, at the federal level, and because I'm a statey, I'll just say the things that are actually moving and changing are at the state level right now. There are laws and changes, and by the way, 36 governors. And the gubernatorial races are up this cycle. So we could see some big changes in the state house and in state legislatures. It is a challenge and an opportunity. One, to be able to articulate, what are we talking about? You see, for this group, you understand what we're talking about. Meanwhile, back at the ranch, people are going through thousands of pieces of legislation. What are we talking about? Why does it matter? How can we stand with businesses to make the business case? It's not about businesses, in all due respect. It's about the consumers that use the power of their dollar to buy the access to that health care. They are the consumer. They are the one who are demanding change. And in my view is that systems are changing around the country. And businesses are changing. Why? Because people are demanding different types of care, convenient care, quality care. Those are the types of drivers that I think resonate with state policymakers. And I would finally say that we heard the previous panel talk about telehealth. You know, it is here. It's the future. The problem is our payment systems, our access points haven't caught up with the technology. It's like we have a bit part in Back to the Future. The future's now. We've got to push forward to say we need to be contemporary with the way consumers want to access care, and then make sure systems value what the taxpayer values. And if we can keep that in mind, all of the regulators and all of the laws can be busted open so that it recognizes a new context for the way consumers want to access care and for the way businesses can provide that kind of care. But I don't have an opinion on this. I want that definitely clear.
Tara?
Just to echo one of those themes, so an important message that we tried to convey in the policy paper was that we think that innovation in healthcare and in the way healthcare is delivered is a very important element of the scope of practice discussion. And it also ties, telehealth is something we've been focusing on a lot. We did a workshop back in March, and retail clinics and telehealth and scope of practice were all central to that workshop. So ideally, all of these changes are driven by the market, not by regulations, right? That it's responsive to consumer demand, and consumer means not just the end patients, but in many situations the consumers are the businesses who are purchasing health insurance and are participating in the design of these systems. So what we try to do is emphasize that we need to remove whatever regulatory barriers are preventing the market from operating to exercise these choices. And it applies to the retail clinics and telehealth and scope of practice and all of those issues. And so we find that coming back to those themes, when we talk to people in the state legislatures who are making these choices, if we remind them that if you can take these regulatory barriers out of the way, let's look at how the markets are operating in the states where the regulatory barriers do not exist, and that those natural experiments are the best lesson for why injecting more competition into healthcare markets will ultimately benefit everybody.
Great. Thank you. I have two questions that go together, and they go to you, Jack. One is, can I have you expand on how to get corporate America to assist with policy changes in specific states? The kind of how to, like you were the CEO of Aetna, could pick up the phone and talk to Marriott and talk to, but I don't think.
And talk to the governor.
And talk to the governor, right. And we might have some of those folks in the room, but lots of people don't have that, and we're trying to get this action going at the state level, of course, so that's the main question, but kind of a natural, I think, corollary to that is, can we have a national conversation with key business leaders to speed up this process rather than only going state to state in this linear way? So that kind of, you're hitting both state and national. How do we really engage with business is really what I'm hearing.
And one of the ways, obviously, gets to the issue of nurse leadership and individual nurses playing roles rather than just a bunch of people sitting here in Washington or in Princeton. You know, we've had experiences where there have been exceptional nurse leaders play exceptional roles, and one has been the president of an Ivy League school, and another one a long-term board member at Anthem, another one a long-term board member at United. So it's not like it doesn't happen, but those are exceptional people. And I think, practically speaking, given the importance of universities and hospitals in local economies, that a little bit of concerted effort, maybe by lobbying search firms that position people on boards. There are search firms who basically have practices where they do board practices. And bringing to their attention that the dean of the school of nursing in their town or region, or the chief nursing officer at the Partners, or, you know, I mean, the chief nursing officer, Partners, whoever he or she is, I can tell you whoever that person is, that person would be a very suitable board member for some major corporation. Yeah, I mean, come on. Probably should be a member of the Federal Reserve Board of Boston or something. I mean, think about it. And so, and in New York, you know, I see the same thing. So if you think about those people, there are hundreds and hundreds of those people across the country, and they have influence in their local markets with the local corporations. And it's some kind of concerted effort to help talk those people into being willing to serve on these boards and help search firms and corporations identify them. That would be, I think, a very effective strategy.
Okay. Good thing we're on it. Or at least we're trying on a leadership effort as well. Well, I don't think we have any other questions coming from the audience, which is really good because we're 5 minutes over anyway. But I just want to ask each of you if there's one last comment or some action you think we should be taking, or any last comment to start. And I'll start with you, Elaine.
Yeah. Well, I've said in the Twitter space and on our blogs at AARP.org that it's time to give nurses more authority to heal. And I think that it is important for folks here and others who will be engaged in the conversation to understand how powerful they truly are. Caregivers, 42 million of them are consumers and the best advocates for change that we have. And our new CEO, Joanne Jenkins, was interviewed with USA Today, and she noted that for the 50-year-old and older population in this country, family caregiving is one of the biggest challenges they face. So to all those family caregivers out there, raise your voices. We'll help you. These rules don't have to be the way they are. And you can make that change and know that you have research, the professional community and the business community all pressing for change and a better future.
Great. And an AARP state office in many cases that will help.
Come to our AARP state office.
Yes, Frederick.
Well, I guess I just want to start by saying just an enormously sincere thank you to AARP for taking this issue on. Boy, is that exciting. And boy, is it forward-thinking. It's wonderful. This is, as you were pointing out, it's a time of great change in healthcare right now. It is really right now at the state level. That is where we're seeing, I mean, that's what I spend all my time with, is helping the governors on that state level change. I think 3 bits of advice. The first is, I can't agree with your point more, and with all of the panelists' point, this is about telling the story of why it matters. It's about the consumer perspective. So when you talk to people, start with the story. For example, my mom, we had to put her on a transport every day or once a month or whatever. That is so powerful because as the policymakers are thinking about this, if you're not grounding it in a narrative that they understand, that's first person, you're going to lose them. 2, prepare them for the other side of the argument. So let them know. You're going to hear this is the other side of it, and here's why it's wrong, right? And then 3, make sure that as you're talking to them, you're grounding your discussion in the evidence base. I can't tell you how important that is. At the end of the day, there will be a conversation where somebody from the other side of the perspective will say, you know, you're going to give poor people worse care because you're giving it to nurses. And having that policymaker say, wait a second, the studies are really clear, it's as good or better, that is super important. So there's 3 things. Tell the narrative, make sure to prepare them for what they're going to hear, and make sure that you're giving them the evidence base.
Very well. I love the way you wrap that up, too. Thank you so much. Tara.
I was going to say all of that. That's great, yeah. So here's what I'll add. So we talk a lot about how we are fully supportive of the concept of team-based care. It is not by eliminating scope of practice restrictions. We are not implying that APRN should be autonomous and not collaborating with physicians. But the example that we often use, the analogy is, we routinely expect that primary care doctors will consult with specialists when they feel that something is outside their own scope of practice. That is the exact same model that, as competition lawyers, we would like to see applied between APRNs and physicians so that everyone is practicing to the top of their license. And so the bottom line is effective collaboration and team-based care does not require physician supervision of APRNs. And that's the way that we try to frame it. That's sort of the bottom line message of the policy paper.
Thank you. Micah.
Again, thank you to AARP, RWJF. Also, I love your white paper. It's featured on the page 1 of our white paper. But I guess what
Geeky endorsement.
I know, but it's so good. Yeah.
And our members don't know about your paper.
Okay, no, that's fine.
Well, we'll see. I mean, because I guess what I want to leave folks with is, let's do this, particularly in California, obviously. But we have a big California's a big state.
Yeah.
1/5 of the signups for the public exchanges under the Affordable Care Act nearly came in the state of California. It's got a Medicaid program that serves now 9 million people. Mm-hmm. And we got the scope of practice bill through a couple of committees. We still have a legislative champion that's ahead of the Senate Health Committee there. We've got a growing coalition led by AARP, also the nurse practitioners, also the business community, also the physician groups. But this is going to be a big, big challenge. And so devoting as many resources as we can, and I know you're already doing that, not just you folks, but the broader community, the business community, we have a big opportunity there so that it isn't just, well, it isn't just, but it isn't primarily boxy little states in the middle of nowhere, but California.
Boxy big state.
Yeah, or boxy, you know, a gigantic populous state like California making this kind of a change would make a huge difference, and we have a big opportunity to do that.
Thank you. Jack.
Recruit some CEO leaders.
Okay. Okay. Well, that was short. Okay, and we'll find out who they are. Well, thank you all. Before I just conclude this panel, I do want to acknowledge Winifred Quinn, Andrew, Bianco, and the whole team for putting this together. And please extend your heartfelt thanks to this wonderful panel.
Thank you.